What is your personal approach to preventative treatment? How do you prioritize things? What do you do?
Right. So when thinking about the oral preventive medications, it's interesting that a lot of people will say, you know, what's your favorite oral preventive? And there is no favorite oral preventive. It's a real process of interviewing the patient and determining whether or not they have any comorbid conditions or coexisting conditions that might benefit from one particular oral preventive over another, or medical problems that you want to avoid using one particular treatment or another. So I think that in a lot of ways there's a real art to it. And as you know, we always start with a low dose. We gradually, increase the dose. Stephanie already mentioned that you have to be patient, and a lot of people don't really want to be patient because we want to try to get the lowest dose that works. But there's no one size that fits all with the oral preventives. So you just have to sort of make the best choice you can, and I'm very upfront with the patient that I may or may not get it right the first time, and we may have to explore some other options, and sometimes we have to combine treatments.
Well, that's going to lead me to two more questions. Stu, how long do you try a medicine before you think it's not going to be working?
As Deb said, it's generally a period of ramping up of the dose, and we know for most of the oral preventive medicines what the optimal dose is, or the range for the optimal dose. And once they're at the optimal dose, I like to have a patient go at least 2 or 3 months before evaluating efficacy. So often this is a 4-month trial. And again, returning to the fact that we're talking about chronic migraine, of the oral preventives, the only oral preventive that really has good, modern, randomized controlled data for efficacy is topiramate, and not one of the oral preventive medicines is FDA approved for chronic migraine. So that adds to the frustration that Stephanie said, is that you're actually trying medicines that either have no evidence for effectiveness in chronic migraine or modest effectiveness and a very long prospect of trial, potentially laden with adverse events.
I just think people should understand that even though topiramate is the only oral preventive that's approved for chronic migraine, mostly the oral preventives, if they're approved for migraine. So it's not that you can't use something that's approved for migraine in a patient who has chronic migraine. I think some people make that mistake.
Yes.
But we'll be talking about the newer drugs later, and they're all approved for migraine. It doesn't just have to be chronic migraine.
I think that's an extremely important point. For most of eternity, there was no difference between episodic and chronic migraine. With the development of an injectable treatment in the past, it turned out it only worked for patients with more frequent headache. Hence, it was given a label for onabotulinum toxin type A for the treatment of headache in patients with chronic migraine. That's when the division began. So I think you need to realize the fact that theoretically, the older drugs never had to be tested for chronic migraine. Because I can tell you, some of the old-fashioned people in the headache world believed you couldn't have a migraine headache every day, and they called it tension headache. So for all intents and purposes, in ancient prehistoric headache times, there was no chronic migraine. It was really chronic tension headache and migraine combination. Or aren't you old enough to remember that still?
Chronic daily headache.
Or chronic daily headache. How about mixing things? Do you mix drugs?
Yeah, I think that we should now think about migraine in terms of striving to achieve a migraine-free state, which is a lofty goal. And it could be looked at in different ways by different providers. But I think if we set this goal of migraine freedom at the top of our mindset, it encourages you to use combinations to try and continually improve the patient's state. And we should no longer be satisfied with monotherapy and maybe a 50% improvement. We should be thinking about synergistic combinations that we can layer on top of each other as long as they're well tolerated, patients can adhere to them, and build that cocktail up to achieve a greater state of migraine freedom.
I think there's been a change. I think that the idea in the past of monotherapy is dead. And I think what we're trying to do is find the right combination of medicines at lower doses with less side effects.
It's very much like treating epilepsy. If you're treating an epileptic patient and they continue to have seizures, you wouldn't stop with one medication.
Or hypertension.
You
Most
keep
of them are
layering
on
them
2 or
on.
3 drugs, right?
Exactly. We have very little evidence to guide us from the scientific literature as to how to combine preventive therapies. In fact, the only NIH-sponsored large trial, double-blind and controlled for this purpose, failed to meet its endpoints and was stopped early for that reason.
for that paper.
But we do it all the time. And in some later studies of preventive therapy, some patients were allowed to stay on their preventive treatment and take the experimental treatment, and they saw a benefit. So I think that we all believe in our heart of hearts that combining therapies is necessary. People ask me if a drug isn't working optimally and you want to change the preventive plan, do you take them off of that drug before you put them on something else? I would say no, unless there is a contraindication to the combination. Why would I pull the rug out from under the feet of my patient who is getting at least some benefit, just suboptimal benefit from their current preventive?
It does raise the question of what is an adequate response.
It does.
So, if someone has a 30% response on a particular medication, should you pull that medicine to switch to the next one?
Never.
I agree with you. You keep the 30% and then you look to add to it if they're not having side effects.
30% is a miracle for some patients.
Can you imagine having headache every day of your lives, and now you have 10 days a month of headache freedom? That's a miracle.
True, but in epilepsy, that's nothing, right? The epilepsy standard is seizure freedom. And I agree with Andy. I think that's what we should be aiming for.
Oh, I'm not disagreeing. But the point is, from the point of view of the patient, a reduction of that burden is the beginning of the end, not the end of the beginning.
And also, in terms of the analogy to hypertension and other disease states, we do have an opportunity to layer on treatments that probably have different mechanisms of action. And migraine has some heterogeneous mechanisms of action, and we can come at this very disabling disorder from different directions by polypharmacy, by co-pharmacy.
Co-pharmacy. I don't like poly.
I
It
knew you
implies
would correct
something
me.
not
That's
true.
why I corrected myself.
Our words matter, don't they?
Okay. In terms of tolerability, Deb, could you tell us something about the extended release topiramate? Who should use it? What are the doses?
Sure. So there are some advantages to using extended release topiramate, and there are 2 different brands that are currently on the market. One is Trokendi XR and one is Qdexy. And certainly one of the advantages is that it has a long half-life, so you only have to take it once a day. And it's hard for a lot of people to take topiramate immediate release more than once a day. In theory, and to some extent in reality, that once a day dosing allows for a much smoother pharmacokinetic profile during the day, less peak and trough occurring during the course of a day. And so it may be that many patients will tolerate the extended release better than they do the immediate release. There have been some studies with Trokendi XR looking at word producing, which we know is a problem with topiramate, that many people have trouble with word finding and memory loss. And it seems that the extended release may also be beneficial for some patients in that regard, really being less likely to cause that word finding difficulty.
How do you start it? Do you go to a full dose? Do you start a lower dose? Do you ramp up?
You start it just like you start regular topiramate. So you start with usually 25 milligrams a day for a week or 2. It has a long half-life, so some people say maybe you should go every 2 weeks instead of every week like we do with the immediate release. And then gradually increase it just by 25 milligrams a day, just like you do with regular topiramate. The dose is equivalent.
So the basic principle of headache prevention for the old classic oral medications is slow and steady wins the race. Start low, go slow. But there may be a change in the paradigm.